The following podcast is part of a certified educational activity titled Checkpoint Inhibition in Gastrointestinal Cancers. Recent advances in gastric, esophageal, and colorectal cancers and their application in clinical practice, featuring Dr. Manish Shah from Weill Cornell Medicine in New York, Dr. Ronan Kelly from Baylor University Medical Center in Dallas, Texas, and Dr. Nilofer Azad from Johns Hopkins University School of Medicine in Baltimore, Maryland. Access the entire activity and complete the post-test at peerview.com/UFG860. Downloadable slides and practice aids are also available.
Hello, and welcome to Checkpoint Inhibition in GI Cancers, recent advances in gastric, esophageal, and colorectal cancers and their application in clinical practice. My name is Dr. Manish Shah, and I'm from Weill Cornell Medicine in New York, and I'm pleased to welcome my colleagues, Dr. Ronan Kelly from Baylor University Medical Center in Dallas, Texas, and Dr. Nilofer Azad from Johns Hopkins University School of Medicine in Baltimore, Maryland. Today's agenda: there's a Masterclass 1 integrating the pivotal data into practice, clinical experience with immune checkpoint inhibitors in colon cancer. Then we have a practicum where we talk a case study, basically, where we weave clinical data into the colorectal cancer treatment algorithm. Then the Masterclass 2 is redefining treatment algorithm for with the advent of immunotherapy in advanced gastric, GE junction, and esophageal cancers. And then Masterclass 3, we progress with immunotherapy in earlier disease settings. And then we'll have 2 cases for patients with esophageal and adenocarcinoma with GE junction and esophageal cancer. So to begin, mechanisms of checkpoint inhibition. I like to start off with this slide because it really highlights what the target is. For all of our cytotoxic therapies, we think of hitting the tumor cell with, our cytotoxic therapy, and most of our tyrosine kinase inhibitors also attack the tumor cell. The effector cell here for the immune checkpoint blockade is the effector T cell, which receives signals from the microenvironment from both the tumor cell and also other antigen-presenting cells like dendritic cells and macrophages. And the T cell actually integrates positive and negative signals from its environment. And if there are more negative signals than positive signals, then the T cell is suppressed. And by blocking these negative signals, either with a PD-1 or PD-L1 inhibitor, as shown above, or a CTLA-4 inhibitor like Nivolumab or Pembro, we can block the negative signals and then hopefully have enough positive signals remaining to activate the T cell against the tumor cell. That's really the basics. It's much more complicated. There are many more positive and negative signals and modifiers, but that's actually the foundation for how checkpoint inhibition works in cancer. And with that, we kind of have lots of new activity in GI cancers. We have approvals for pembrolizumab and nivolumab and ipilimumab in colorectal cancer. We have approvals for pembrolizumab and nivolumab in gastric cancer, and also approvals for both in esophageal cancer, particularly esophageal squamous cell cancer. And then we also uniquely have tumor-agnostic approvals for mismatch repair deficient tumors, also known as MSI-high, and then most recently, TMB-high tumors, which are defined as greater than 10 mutations per megabase pair. And we're going to talk about all of this today. And with that, I'm going to hand it over to Dr. Azad. She is a leader in developmental therapeutics and the director of developmental therapeutics at Johns Hopkins, and she'll talk to us about our experience in colorectal cancer.
So thank you very much, Dr. Shah, for inviting me here today and to let me talk about this really exciting area of how we can treat colorectal cancer patients right now, which is treating a certain subset of colorectal cancer patients with immune checkpoint inhibition. And I think as we start this conversation, we really need to frame it with the reality of what colorectal cancer is, which is really 2 very distinct, different diseases. Any of us that take care of colorectal cancer would probably even argue that that's an oversimplification, that each individual patient is very different from another one. But if you look at colon cancer in general, there really are 2 major buckets that patients divide into. The first one is the group of patients that are mismatch repair proficient, or we call that microsatellite stable. That's the vast majority of colorectal cancer patients. 85% overall, 95% of metastatic patients. And these patients are going to have intact mismatch repair proteins as compared to the other 15% of patients. Really, this is where immunotherapy with immune checkpoint inhibitors has effect. So this is a small subset of patients. In the metastatic setting, that's only 5%. And there's other clinical features that go along with MSI high patients as well. They're more likely to have right-sided disease. A subset of these are going to be Lynch syndrome patients. So that's our genetic predisposition syndrome that predisposes patients and their family members that are afflicted with increased risk of colon cancer and endometrial cancer, ovarian cancer. But that's actually only a small part of MSI. Most MSI high patients actually don't have a genetic predisposition. It's sporadic. It comes from an abnormality in one of those same proteins, but not from a genetic predisposition. And those patients are more likely to have BRAF mutations and have that as a potential option as well when it comes to treatment. So if you look across all tumor types, what you're going to see is that MSI is rare. It's about 4% of all cancers. In colon cancer, colorectal cancer, that number is higher, so about 20% of colon cancer. But we do see microsatellite instability in other tumor types. And in colorectal cancer, we've got one of the highest rates of microsatellite instability. So what does that mean for us when we are confronted with a patient walking into our office for the first time? And what the most important thing is when it comes to how we interact and deal with that patient's care is that every single colorectal cancer patient should have microsatellite instability testing done as standard of care. And this is true for early stage disease as well as stage 4 disease. And MSI testing can be done in a lot of different ways. So you can do mismatch repair testing using immunohistochemistry, which is just tumor staining on tumor tissue. It can be done by next generation sequencing, by PCR. All of these methods are completely valid to be able to assess microsatellite instability, but every patient should have this assessed because in early stage disease, this has meaning even when it comes to adjuvant therapy, especially in stage 2 patients. Most of those patients should not be treated with adjuvant therapy, but you do have these high risk stage 2 patients that you ponder giving adjuvant therapy to because they have other high risk clinical features. But if they're microsatellite unstable or MSI, they're going to actually have an excellent prognosis, and they're not going to likely benefit from 5-FU-based adjuvant therapy, especially monotherapy. So it has meaning in the stage 2 setting in terms of prognosis and stage 3 disease. And then, of course, as we're going to spend most of our time, it has some important meaning for stage 4 disease in terms of treatment. And of course, it also allows us an opportunity to be able to test patients for Lynch syndrome, which may have important meaning for them and, of course, for their family members as well. So another important reason to be testing our patients. So what does this mean in terms of therapy for our patients? Well, the first thing that we realized with the earliest trials in microsatellite unstable cancers was that in the second and third line setting, immunotherapy with PD-1 inhibitors has proven benefit. And this is the NCCN guidelines that we've put here in front of you that show that Nivolumab and or Ipilimumab or Pembrolizumab only in mismatch repair deficient patients has a role in both second and third line plus disease. And this was initially demonstrated with a pivotal series of trials that were done by my colleagues at Johns Hopkins looking at pembrolizumab across patients that had mismatch repair deficiency. So you can see here, this wasn't just colorectal cancer, but this is an impressive waterfall plot showing activity across all different tumor types that were MSI high. And this led to the very first tumor agnostic indication for a drug in cancer patients when pembrolizumab was approved in this group. We have since had others as well, but this really paved the way for that kind of approach in how we treat patients. So in colon cancer, though, we have even stronger and more specific data. And this is the larger study, Keynote 164, This was the study that helped pembrolizumab also get approved for MSI-high cancers, but this study was only colorectal cancer. Cohort A was heavily pretreated, so more than 2 prior therapies. Cohort B was just 1 or more prior therapy, and then these patients were treated with pembrolizumab. And what we saw in this study was that in both Cohort A and Cohort B, which was the more heavily pretreated and less heavily pretreated cohorts, we had around a 30% response rate, and even at 6 months, the progression-free survival and overall survival were quite impressive compared to our historical controls of regorafenib and TAS-102. I do want to draw your attention to the 7% of patients that experience severe drug-related reactions. I just want you to remember that number because when we start talking about nivolumab and ipilimumab combinations, that comparison is going to be really important in terms of which regimen that we should choose. And so speaking of nivolumab and ipilimumab, the study that looked at that in the heavily pretreated or already pretreated setting was Checkmate 142. This is a trial that looked at nivolumab plus the CTLA inhibitor ipilimumab in patients with MSI-high colon cancer, and patients were randomized to either nivolumab alone or the combination. And you can see it was a nice size study, 74 patients in the Nivo arm and 119 patients in the nivolumab plus ipilimumab arm. This is also a very impressive waterfall plot. The single agent response rate of nivolumab was 34%, so very similar to what you just saw with pembrolizumab, but the overall response rate of the doublet was 55%, with over 80% of patients having disease control. And so this was a very impressive study in terms of benefits seen and really allows us to consider this importantly as an option as well. If you look here at the durability of that response, here's the progression-free survival and overall survival at 9 and 12 months. You see a very nice separation of the curves when you look at the doublet compared to single arm, especially when we look at progression-free survival. But even the overall survival here looks better compared to the single agent. Here we have new data over the last year about moving this up front into first-line therapy for our colorectal cancer patients. This is our newest approval in colorectal cancer just this past year of pembrolizumab or nivolumab and ipilimumab in the first line, and allows us to really consider these options as soon as a patient is diagnosed with metastatic disease. The pembrolizumab is the FDA-approved indication. The nivolumab and ipilimumab is allowed with these NCCN guidelines, but doesn't have official approval. Keynote 177, this is pembrolizumab versus investigator choice chemotherapy. And you see all of our favorite doublets here of FOLFOX and FOLFIRI with various targeted agents. Patients and their providers could choose which one they wanted to do if they were randomized to the standard of care chemo arm. And importantly, crossover was allowed where patients were allowed to get pembrolizumab if they progressed on chemotherapy, making overall survival quite difficult to assess for this cohort. But if you look at the PFS, if you look at the duration of response, there's really a magnificent benefit for ICI therapy for this group of patients. The 24-month progression-free survival is 48% compared to 19% in the chemotherapy arm, and the duration of response hasn't even been close to getting to the median at this point, even with a median follow-up of 32 months. So really, really exciting data that has resulted in FDA approval of Pembro in the first line. Now, Dr. Lenz and his colleagues have reported and will continue to update the report of Checkmate 142 here at ASCO GI as well. This is nivolumab plus ipilimumab in the first line. Smaller study, 45 patients and non-randomized. But as you can see here, 60% response rate, so very similar to what they showed, what has been shown previously in the second and third line with the doublet combination. Over time, that increased slightly to 69%. But the other thing I really want to draw your attention to is the time to response. It's down here, it's 2.6 or 2.7 months. And this really shows what we see in the clinic all the time with these patients as well. Patients with MSI-high disease respond quickly and early to immune checkpoint inhibitor therapy. There is a slightly increased response rate over time, but really we see very quick responses with this regimen. And the other thing that hasn't been well described is pseudoprogression in this patient population. As someone who's treated a lot of these patients, it's not something that I see very commonly or at all. And I think that it's an important thing for us to remember in terms of whether these patients should be treated past progression when they have a PD-1 inhibitor on board. If we look at the subgroup analysis of this trial, the important subgroups that we know are meaningful in colorectal cancer, both in terms of performance status, but also mutational status, left versus right-sided disease, which I think we should be reporting for all first-line studies, if not all trials with colorectal cancer now. And there was benefit seen across all of these different subgroups. I do want to remind you about that 7% that I told you to remember in terms of grade 3 adverse events with pembrolizumab alone. 22% in this population. Most of them were able to be resolved, but we know that these are serious, life-threatening events for many of these patients. They definitely put them at risk, and this is the major thing that we need to consider when we're trying to decide whether we move forward with doublet therapy versus single agent for MSI population. Now, the one other group of colorectal cancer patients that deserve consideration of PD-1 therapy are patients with a high tumor mutation burden, even if they have microsatellite stable disease. And this is data that initially was really validated in other tumor types. So initially in melanoma, and then non-small cell lung cancer, bladder cancer, places where we know ICI therapy works, people did very important analyses looking and showing that TMB, tumor mutation burden, was an important predictive biomarker of response and benefit from therapy. This has been looked at more broadly now across tumor types, and it also is really satisfying because it makes a lot of rational sense why this would be so. So every mutation that a tumor has is another opportunity for the immune system to recognize an abnormal protein as abnormal and attack that cancer cell. And so the more tumor mutations that you have, the more it makes sense that you have a higher chance that the immune system would recognize one of those mutations as foreign and attack that cancer cell. And indeed, Keynote 158 demonstrated this, looking at TMB high versus TMB non-high tumors and showing an improvement in progression-free survival and over time an improvement in overall survival if you look at these Kaplan-Meier curves. And a TMB of greater than 10 now is an FDA-approved indication for immune checkpoint inhibitor therapy as well. We spent a lot of time talking about rare subsets of colorectal cancer, but that still leaves 95% of our metastatic patients that we can't treat with standard of care immune checkpoint inhibitor therapy. And that's really the biggest dilemma that many of us in this field are trying to tackle now. And these two figures, I think, really do a great job of explaining what the problem is. If you look here on the left, what you see is that cancers really segregate into a few different groups of tumor microenvironments. In particular, you have these inflamed tumors. Tumors like lung cancer and melanoma, many of these are the inflamed tumors that we think about. And when you look at these microscopically and biologically, you're seeing many different immune cells that are infiltrating that tumor microenvironment. You're seeing cytokines being secreted that are ripe for immune activation. And on the other hand, you've got almost all the other tumors, including colorectal cancer and most tumors, where you've either got an immune desert or an immune excluded or a combination where basically the immune system is either not present because of the stroma and the exclusion of immune cells, or there are immune cells there, but they're immunosuppressive cells that are really tamping down the immune response. And here on the right, this figure actually looks at within colon cancer an attempt to summarize all of the different kinds of cells and proteins that are both good for fighting cancer and oppose an anti-cancer effect. And every patient every one of their tumors has a different balance of all of these different factors. And that's why it's so challenging to come up with a single regimen that will be able to treat all of these 95% of patients that live in an immune excluded environment. But we have a lot of weapons in our armamentarium. Immunotherapy is not just a PD-1 inhibitor or a CTLA-4 inhibitor. Those are good and important weapons, and we might want to add to them, but we also have vaccines. We have adoptive T-cell therapy where we can give back immune cells to patients that are programmed to attack the cancer. We have targeted drugs and epigenetic drugs that can be used to overcome immune resistance circuits. We have cytokines. We have so many different kinds of therapies that also count and are immunotherapy and immune modulating agents. And this figure and table is just a small example of the number of immune combinations that are being tested. These are on the left, you see some of our most common PD-1 and PD-L1 inhibitors. And this is just a group of studies that is scratching the surface of the different studies that are being done right now for our metastatic colorectal cancer patients. So there's a lot of different interesting rational combinations that are being explored. And the goal is for us to move past this. This is all of the initial trials of Nivolumab and PD-1 inhibitors in colorectal cancer. And you can see none of it worked. Response rates of 0, one patient with a response in the initial paper here that was the MSI patient, that this actual patient was the one responsible for why the entire investigation for MSI high began. But overall you can see PD-1 or CTLA-4 alone does not work for colorectal cancer. But what can we do to combine things or come up with new strategies? And this is one example. Some colleagues of ours at Massachusetts General Hospital, Aparna Parikh and Ted Hong's work, but there is so much work ongoing that also mimics the rational strategies that can move forward when it comes to our tumor type. They hypothesized that if you gave low doses of radiation to a patient, you could use the radiation actually to create more neoantigens, more opportunities for the immune response. And then if you gave patients Nivolumab and Ipilimumab, perhaps at that point we could see a response even in microsatellite stable patients. And so they designed this study, gave microsatellite stable colorectal cancer patients this therapy, and what you can see is that they did see some patients that benefited from this therapy. 15% response rate in those who were able to go on to actually get at least some radiation. 37% of those patients had disease control, so over 50% of patients had some benefit from this strategy. And they are looking at moving this into a larger trial. And I have seen and hopefully will be seeing more and more studies like this that are rationally designed combinations that can start targeting our big 95% microsatellite stable cancer patients. Before I leave you tonight, I'd love to highlight a study that's open right now across cancer centers and practices across this country. That's atezolizumab plus FOLFOX for patients with stage 3 cancer that have mismatch repair deficiency or MSI high. This is a trial that is aiming to move immunotherapy earlier into therapy into stage 3 disease. Patients can even have received a cycle of FOLFOX as they're being identified and referred for this study. And I think in rare patient populations, it's going to be really important that we all work together to enroll these kinds of important studies. And so with that, I'd love to leave you with just a few final thoughts. First, that we should be testing all patients with colorectal cancer for mismatch repair deficiency. Many different ways that we can do this, but every patient should get mismatch repair or MSI testing. We know that mismatch repair deficiency predicts for benefit from immune checkpoint inhibitor therapy. So all patients that have metastatic disease now have an FDA-approved indication in the first or second line plus for either single agent or PD-1 plus CTLA-4 therapy. And finally, I hope that we'll be getting together very soon to talk about exciting data that should be reported on many clinical trials that are ongoing for patients with microsatellite instability and immunotherapy too. So we're going to move forward into our patient case studies. The first one that I'd like to highlight is a case of a 60-year-old gentleman who presents to the office with right-sided microsatellite unstable disease. He has a very uncomplicated past medical history, really had never been to see a doctor before, but presented with advanced disease, and now comes to discuss initial therapy.
So terrific talk, Dr. Azad. So what would you use for this patient? We just presented data on Pembrolizumab, which is FDA approved, but there's also exciting data for Nivolumab and Ipilimumab.
So because of the majority of patients that even get single agent therapy and have benefit, so not just response rate, right? The progression-free survival and the stable disease rate of single agent therapy is still very high. So I really thread this needle by usually starting patients on single agent therapy with Pembrolizumab or Nivolumab.
And if someone doesn't respond to single agent therapy, do you then add the CTLA-4 inhibitor?
So that's a really interesting question. So there hasn't been a study that has really looked at in a rigorous way the idea of adding CTLA-4 inhibition to overcome, to overcome resistance from PD-1 inhibition. I'm going to admit that I've done it a couple of times and it has actually worked out well, but those are just anecdotes. There are, by the way, ongoing studies nationally that are looking at these refractory patients that don't benefit from PD-1 inhibition, looking at combining therapy with other kinds of immune modulators. So I would say ideally refer for a clinical trial so we can really study this and have something good over time for all of the patients. That would be what I would ideally recommend.
Terrific. And then
I'll move on to another case where if we took this patient and decided actually to initially give him Capox and bevacizumab, he progresses on first-line therapy. Now what would we consider for second-line therapy in this patient?
Right. So as you said, both Pembrolizumab and Nivolumab, or Nivolumab and Ipilimumab are indicated in this setting, and they have very good data. I'm struck by the fact that the patient's a little bit younger. And in the Nivo-Ipi combination, Dr. Lenz's study, I know that was first line, it suggested that younger people actually had a higher response rate. Do you find that to be true?
So I always have found that in kind of an interesting line item in that study, but so many of these patients are young because they're Lynch syndrome patients that I'm not sure that I feel like I can make that determination based on just the kind of the skew of the patients that we see. Once a person has already gone through chemotherapy and they're at their second line, conversely, this is a place where sometimes I'm a little bit more aggressive, especially if their disease burden has increased substantially. And so where I have been using doublet therapy has been in places where if a patient has a big disease burden and I'm worried that they're in some kind of impending failure, or if they're very symptomatic. Now this patient isn't, but if a patient has very symptomatic pain and I know that by getting a better response, an increased response, I might be able to really help them in terms of pain control. This hasn't been well studied as a way to get patients to curative surgery, but that's also a place where I've been a little bit more aggressive with doublet therapy as well. So I think there are a lot of reasons to consider the doublet therapy.
It's interesting. So I actually had a patient, as an anecdote, but he received 2 years of Pembrolizumab, MSI high, nodal disease that was unresectable and metastatic. And he had a tremendous response and was doing really well. We took him off therapy after 2 years, and that's actually a question to you if that's what you do as well. But then 2 years later, so now 4 years from his initial treatment, he recurred, started to grow again. And at that point, I did the doublet because I didn't know that the single would work. Have you had anything like that? And do you stop treatment after 2 years?
So I do stop treatment after 2 years, and I have even stopped treatment earlier if someone developed an immune toxicity, and I've found these patients to have very durable responses even off of therapy, even frankly if they get treated with steroids for their immune adverse event. I have done the same as what you've done. So when patients have recurred I've often thought maybe the CTLA-4 inhibitor might, help with exhaustion if that's part of the issue, and so I've added that on, and that makes sense to me as well. I think when we look at these rare tumor types, we always like to kind of operate where there's randomized big data, but when it comes to rare subtypes and then kind of small rare groups of those rare subtypes, sometimes we have to go with what makes rational sense, even if we don't have strong data that can say, okay, there was a randomized trial that showed that that was the right thing to do.
No, I totally agree. Let's look at audience questions. So here's one. So if you have a patient with both a BRAF V600E mutation and is TMB high, let's say 15, which would you choose?
So clearly you could choose either. I strongly would choose the immunotherapy option though. BRAF mutation positive disease, the work that's been done in that setting is so wonderful for that really difficult patient population, but those responses are not durable the way that immune checkpoint inhibitor responses are. And so, hopefully the patient will be able to get both. Really, hopefully, if you treated them with immunotherapy, they wouldn't need a second regimen. But I think you're much more likely for the patient to have options to do both if you start with the immune checkpoint inhibitor.
Here's another question, and this is, speaking to the toxicities that we've talked about. And, one thing that we should maybe highlight is that the toxicities for checkpoint inhibition are different than cytotoxic therapy. But maybe, Dr. Azad, could you highlight sort of differences in profiles between the doublet and the single, PD-1 inhibition in terms of toxicities? Are there things that you worry more about?
Sure. I mean, if you look at the kind of laundry list of side effects that you can get with CTLA-4 or PD-1 inhibition, they're the same, right? You're going to list the same ones. But you just see that with CTLA-4 inhibition, either alone or in combination, it's just a much more potent drug when it comes to autoimmune phenomena. And so you see more colitis, especially in colon cancer patients, but you see pneumonitis more commonly than you would see by a single agent. But you still see it's still a minority of patients. So it's really about educating the patient so that they're aware, so they let you know. I mean, just to your point, there are different side effect profiles, but the other thing that's different is if you intervene early, it makes a much bigger difference than if you have a cytotoxic chemotherapy side effect, right? And so just making sure that you educate patients about how it can be this snowball effect, I think is really effective, especially if you choose doublet therapy.
Right. And then I think we have one last question about the TMB, which is really exciting. So is there, we've seen, the question is about intermediate TMB. Well, do you define that, and is that important for the approval?
So it is very important for the approval. The approval is for a tumor mutation burden of 10 or above. TMB intermediate is kind of this fuzzy term, but you will see it in the literature because over the 5 years that this was being debated, different groups were defining high TMB differently. So some groups were defining it as greater than 20, with 10 to 20 being intermediate. Some groups were defining it at 10, with 5 to 10 being intermediate. But what the important thing, the take-home point is, if your patient has a TMB greater than 10, they have an FDA-approved indication to be able to get immunotherapy.
So I'll be talking about the Masterclass 2, which is redefining the treatment algorithm with the advent of immunotherapy in advanced gastric GE junction and esophageal cancers. So this is a high overview of the current treatment options for gastric cancer. And, it's very different now than it was 15, 20 years ago when there was maybe one or two kind of boxes here, but now we have several. So first, in the first line setting, it's important to know if you're HER2 positive or negative. If you're HER2 positive, you should consider a platinum doublet with trastuzumab. In the first line setting, HER2 negative, you would consider, most people would be a platinum doublet. If you have a high disease burden or a younger patient, you might consider a platinum-based triplet. And then recently, we'll talk about this, for CPS 5 or higher, Nivolumab with chemotherapy had very good data and is an emerging, or actually an approved approach based on the NCCN. In the second line setting, you need to know MSI high status. If you're MSI high, you would consider pembrolizumab. If you're negative, you would consider a standard cytotoxic option like paclitaxel ramucirumab, but other options exist like ramucirumab monotherapy or irinotecan or paclitaxel. And then in the third line setting, there's an emerging approach that we heard about at ASCO last year and recently published in Lancet Oncology, which is for HER2 positive patients, TDXD, which is trastuzumab deruxtecan, that had incredible activity in the third line setting with response rates of 50%, which is really amazing. But if you're HER2 negative, you have pembrolizumab in the United States for CPS1 or higher. You have irinotecan if you didn't use it in the second line setting. You have TAS-102, which is approved in the United States and Europe. And then in Asia, you have Nivolumab approved independent of the PD-L1 status. So you have lots of options. And I think let's go through some of the data. So to begin with, in third line, Keynote 59 looked at pembrolizumab monotherapy in third and fourth line, and we see that PD-L1 positive patients really had the most benefit, and you can see the duration of response of 16 months. So it's based on these data that pembrolizumab was approved for CPS 1 or greater in the third line setting. And here I talked about CPS, that's a combined positive score. Really what we're doing here, and thinking back to my original introduction, the T cell, the effector T cell or the CD8 cytotoxic T cell integrates the positive and negative signals from the microenvironment. And PD-L1 is a negative signal. And PD-L1 can be presented by tumor cells as well as lymphocytes or macrophages. So the CPS score is the combined positive score. All the PD-L1 positive staining cells, tumor cells, lymphocytes, macrophages. In essence, it's like the microenvironment PD-L1 score over the total number of viable tumor cells. That's your CPS score. And anything 1 or higher for gastric cancer means that you're positive. And then this is the kind of overall summary. So in the third line setting, the response rate was 16%. In the fourth line setting, it was 6%. So it highlights to me that at earlier lines of therapy, you might see better activity. And again, the PD-L1 positive in the third line, 22% response rates, which is really quite good. And then there were a few patients who were MSI high. We just heard about the activity in colon cancer for MSI high. It's active in gastric cancer as well. And so around 25 to 60% of gastric cancers are PD-L1 positive. And there are higher response rates with higher PD-L1 score and earlier lines of therapy. And then Attraction 2 was done around the same time, and this is a phase 3 randomized study of nivolumab versus placebo in the third line setting or greater, and you see clearly that nivolumab had significant better benefit in overall survival. And importantly, the tail on the curve is what we're talking about here. At 1 year, a quarter of the patients are alive with nivolumab, which is fantastic, and that largely contributed to the hazard ratio of 0.63. So this data led to the approval of nivolumab in Asia in the third line setting. And then Javelin 300 was a third line study of avelumab versus chemotherapy. And unfortunately, this study did not show benefit. And I think this highlights that there are third line chemotherapy options that have activity. It's not to say that a PD-L1 inhibitor wouldn't work in gastric cancer, but unfortunately, this study for me really highlighted that chemotherapy does have activity in the third line setting as well. Moving to second line, Keynote 061 compared pembrolizumab versus taxane-based therapy in the second line setting, and again included all comers. And on the left, we see the CPS 1 or less. CPS less than 1, and you see that pembrolizumab is inferior to chemoctherapy in this population. So this highlights that before using pembrolizumab, you need to know the CPS score. If your CPS score is 0, then you would be doing harm to be giving patients pembrolizumab if there's a cytotoxic agent available. The primary endpoint for this study was CPS 1 or higher. That's the middle Kaplan-Meier curve. And we see that it's close, 0.82. Really, that's driven by the tail on the curve. So those patients who do respond to checkpoint inhibition have a longer, more durable response and better long-term outlook. But in the first 6 to 9 months, you see that chemotherapy is doing better. And then if you enrich further, CPS 10 or higher, this was an exploratory analysis, you begin to see a benefit of immunotherapy alone. And then this leads us to perhaps the combination studies. We heard earlier about novel ways to improve the response to checkpoint inhibition. Here are some of the rationales for why we would combine an anti-PD-1 agent with chemotherapy. First of all, you could reduce the tumor bulk, and that could improve the T cell to tumor target ratio. You could eradicate immunosuppressive cells and improve T cell penetration, and you may prevent early disease progression or death. Particularly for gastric and esophageal cancer, I think you'll know that these patients have a high tumor bulk, and if you don't respond to therapy, you may kind of lose the option for more therapy. The con of the combination is that you might actually, the cytotoxic chemotherapy might kill effector T cells, and you have to use corticosteroids as well. But so Keynote 62 was the first to examine the combination of Pembro with chemotherapy in the first-line setting. It also looked at Pembro versus chemo as a non-inferiority study. So it was a 3-arm study, one arm getting Pembro, one arm getting Pembro plus chemo, and the other arm getting chemo alone, typical standard FOLFOX. And the primary endpoint was actually this left group of columns, which is CPS 1 or higher. And if you compare Pembro versus chemo, you see that there is overall similar results, overall survival 10.6 versus 11.1 months, and that was non-inferior technically. And then if you combine Pembro plus chemo versus chemo, you don't see that much more benefit in this population. However, Checkmate 649 recently was presented at ESMO, and it also similarly has a 3-arm study looking at Nivo-Ipi versus Nivo plus chemotherapy versus chemotherapy alone. And we have the results of the chemo plus or minus Nivo study, and the primary endpoint was CPS 5 or higher, and we see that Nivo plus chemo was really significantly superior to chemo alone. The hazard ratio was 0.71, and we see finally a median overall survival of more than a year, 14 months. So this is really quite exciting. If you look at the boxes, we see CPS 1 or higher, the hazard ratio creeps up to 0.77, and then in all randomized patients, it creeps up to 0.8. So, of course, we don't know what the FDA approval will be for this study, but you can tell that, most of the benefit was with CPS 5 or higher. With the hazard ratio creeping up to 0.8, it suggests that for the CPS less than 5 group, the hazard ratio was probably higher than 0.8, closer to 0.85 or 0.9. So, of course, that's conjecture. We'll see what the FDA approval shows, but I think for sure this is a practice-changing study. And this is the subgroup analysis, and we see that across all subgroups, there was clear benefit of the addition of Nivolumab, and of course, the MSI high status, those few patients, there were 34 that were MSI high, there was a really striking benefit with checkpoint inhibition. And then in the first-line setting, Java 100 looked at maintenance of Nivolumab versus chemotherapy, and again, this was a negative study, so it really does suggest that chemotherapy is active in the maintenance setting, and probably not a good option. There were subgroup analyses of looking at the MSI high group, both in Keynote 61 and Keynote 62, and we see it's a small number of patients, but those patients really did quite well with pembrolizumab. So it really highlights the importance of knowing MSI high for this population. And then notably, MSI high tumors or mismatch repair leads to a high tumor burden. And similar to what was presented earlier, this is an exploratory analysis of high TMB. This is looking at 306 patients, and you see that there were a few patients that had high TMB of 10 or more. 18 received pembrolizumab, 17 received chemotherapy, and there was a striking benefit with pembrolizumab. So it highlights the importance of high TMB in this population as well. And looking at exciting combinations, many of you saw this poster presented at ASCO today, lenvatinib and pembrolizumab, and it's really quite striking. The forest plot shows that everyone responded, which I honestly haven't seen previously, and many patients had a significant response. The overall response rate was 70%, and in CPS 1 or higher, it was 84%, which is really quite exciting. So that is actually leading to a phase 3 study, which you'll be hearing about. And then there are other exciting studies. So Rigo Nivolumab was presented previously and published, and this is both the gastric and colorectal cohort, and you can see similar activity, which is really quite striking. So there is hope of these TKI-IO combinations showing some benefit. And then we would sort of highlight some ongoing studies that were presented in trials, TPS studies, trials in progress studies today. And then here are some phase 3 studies that we just talked about, Keynote 62, 649. Traction 4, I didn't mention, it was also presented at ESMO. And the primary endpoint was progression-free survival, and it was quite superior. There wasn't an improvement in overall survival in this study. And then Keynote 859 is an ongoing study of chemo plus Pembro versus chemo alone. And it's a larger study, and hopefully that will be in line with Checkmate 649. And then there are a lot of combination studies with HER2-positive disease. Keynote 811 was based on a phase 2 study presented at colleagues from Sloan Kettering, which looked at trastuzumab and pembrolizumab with cisplatin and capecitabine. It was really quite striking, and that led to this registration phase 3 study. The Mahogany study is a phase 2/3 study, which is built on margetuximab, which is a novel HER2 targeting antibody, which was modified to increase ADCC. The Antigua study, which is looking at the addition of ipilimumab to combination therapy. And then we have Destiny-03, which is trastuzumab deruxtecan monotherapy and in combinations. And then there's the phase 1b/2 Panthera study looking at Pembro, trastuzumab in combinations as well. So these are all exciting studies advancing the field in HER2 targeted therapy. And then here are some highlights of some abstracts that were presented today. The genomic pathway of gut microbiome for nivolumab efficacy, the DELIVER trial. There was the study looking at angiogenesis-related factors associated with the efficacy of nivolumab, and then the Key Largo study looking at first-line Pembro and capecitabine and oxaliplatin in gastric cancer. So a lot of activity in gastric cancer that we reviewed today. And then moving to esophageal cancer, similarly, starting at third line, we have Keynote 180. It enrolled both squamous cell cancer and adenocarcinoma, and we see modest response rates, a little bit higher in squamous cell cancer, but some activity in adenocarcinoma as well. And we see here that the cutoff for CPS was 10 versus less than 10. That was the median cutoff approximately, and that's where there seemed to be more benefit for pembrolizumab. And then Keynote 181 was similar to gastric cancer, a second-line study of pembrolizumab versus investigator choice of chemotherapy, either a taxane or irinotecan. And here we see some benefit in CPS 10 or higher. It didn't quite meet the p-value cutoff for the multiple testing, but the squamous cell cancer subgroup that was CPS 10 did meet that cutoff. But we see the activity in squamous cell cancer and then all comers, the intention to treat analysis, which really showed minimal activity there. You can see the overlapping Kaplan-Meier curves. And then Attraction 3 was the second-line nivolumab versus chemotherapy purely in squamous cell cancer, and we see a significant benefit of nivolumab in squamous cell cancer. We've seen these curves cross over. So initially in the first 2 to 4 months, we see chemotherapy doing better. I think this speaks to the burden of disease for both esophageal and esophageal and gastric cancers. But once you get past that, you see the activity of checkpoint inhibition, and it's really quite durable. And even at 2 years and 2.5 years, you see nivolumab better than chemotherapy. So based on Attraction 3 and also Keynote 181, we have approval of checkpoint inhibition in squamous cell cancer in the second-line setting. Based on Keynote 181, pembrolizumab is approved for CPS 10 or higher squamous cell cancer, and based on Attraction 3, it's approved for all squamous cell cancers in the second-line setting. And this is the Attraction 3 3-year follow-up, and we see that the median overall survival benefit is maintained. The hazard ratio is 0.79, and in patients who responded, you have a survival of about 20 months, which is really quite remarkable in this disease. And there's no new safety signals. So it's really good data. And then finally at ESMO, we have Keynote 590 that was presented. This was a first-line study looking at chemotherapy plus or minus pembrolizumab. This was a global study that included both squamous cell cancer and adenocarcinoma of the esophagus, and the stratification factors were Asia versus non-Asia, squamous cell cancer versus adenocarcinoma, and ECOG performance status. And there are dual primary endpoints, overall survival and PFS. And we can see, based on this Kaplan-Meier curve, that the addition of pembrolizumab significantly improved overall survival. The hazard ratio of 0.73, p-value highly significant. And this was also true in all the different other subgroups. So squamous cell cancer, CPS 10 or higher, you see a hazard ratio of 0.57. That's the most benefit. In all squamous cell cancer, hazard ratio of 0.72. CPS 10 or higher, hazard ratio of 0.62. And then in all patients, hazard ratio of 0.73. So we'll see, similar to Checkmate 649, we'll see kind of what the FDA will decide here, where the efficacy stands. But clearly we see that if you have a higher CPS score, squamous cell cancer, you'll have more benefit, but there is some benefit in high CPS adenocarcinoma as well. And then this is the subgroup analysis, and we see both for overall survival on the left and progression-free survival on the right. We see that across all different prognostic factors, there seems to be benefit with the addition of pembrolizumab. I might highlight at the bottom CPS greater than 10 versus less than 10. That would argue that CPS 10 or higher might be important for approval. That's true for both overall survival as well as progression-free survival, where we see a distinction. And then looking at histology, we talked earlier that in more advanced settings, squamous cell cancer has more activity, but the adenocarcinoma group in this population, the hazard ratio is 0.74, very similar to the hazard ratio for squamous cell, 0.72. So it suggests to me that an earlier line adenocarcinoma in combination with chemotherapy, checkpoint inhibition may be really quite active. And so these are the current standards of care. In the first-line setting, platinum plus fluoropyrimidine, mostly use FOLFOX, but cis-5FU is used. You might use a triplet if you have a significant disease burden. If you have adenocarcinoma and you're HER2 positive, you would consider trastuzumab. But we just talked about the practice-changing study, both Checkmate 649 as well as 590. For adenocarcinoma CPS 5 or higher, you might consider nivolumab. For CPS 10 or higher, esophageal cancer, you might consider the addition of pembrolizumab. You'll have options. Both of these are listed now in the NCCN guidelines, and we're awaiting FDA approval. In the second-line setting, for squamous cell cancer, nivolumab is approved. For CPS 10 or higher squamous cell cancer, pembrolizumab is approved. And for all mismatch repair deficient tumors in the second-line setting, pembrolizumab is approved. You might consider combination therapy like paclitaxel ramucirumab or ramucirumab alone. And then in the third-line setting, we have trifluridine tapiracil for adenocarcinoma. For CPS 1 or higher gastric and G junction, you have pembrolizumab. And in Japan, you have nivolumab in the third-line setting. So we have lots of options that are emerging, and these are for HER2 negative patients. And then we'll move to Dr. Ronan Kelly for Masterclass 3.
Great. Thank you, Dr. Shah. It's a pleasure to be here. We're going to change track really completely now. The last hour or so, we were talking about metastatic disease. And it's exciting to present some data in early stage tumors. And I'll remind the audience, just up in the last 3-4 years, the only early stage approval in solid tumors has been in the melanoma setting. And so for us now to have a positive study in a GI tumor in early stage disease ahead of lung cancer and kidney cancer and bladder cancer is really quite an achievement, I think, for this field. So what we'll talk about is the design of the Checkmate 577 study. But just by way of background, in the United States, neoadjuvant chemo radiation followed by surgery, so-called trimodality therapy, is really a widely used standard of care. And unfortunately, we all know that not all of our patients derive significant benefits. We've seen over the years about 25 to 30% of patients have a pathologic complete response, but that still leaves the vast majority of patients, approximately 70% to 75%, who don't have a path CR. And we don't know what to do with those patients. We know that those patients that are lymph node positive on their surgical resection are really not in a good place because they can recur quite early. And the risk of recurrence is high across all, with only about 50% recurring within a few number of years. So we needed to do something to see if we could improve the outcome for these patients. So in those patients around the country that get chemo radiation and don't have a PAT-CR, we often have debates about whether there's a role for additional chemotherapy. Unfortunately, there's no data showing that that is efficacious. Patients are also frail following a very large procedure like an esophagectomy. And so we wanted to study whether immunotherapy in an early stage setting could be beneficial. We know, as we've seen, that overall it's pretty well tolerated in the metastatic setting. And we were hopeful that even in patients who are even stronger with early stage disease may tolerate treatment better than in the metastatic setting. Just by way of background in terms of trying to understand, is there a difference? This is some data we published in 2018, because the challenge with using PD-L1 expression to guide all of our treatment decision makings, like what we've seen for the last hour, where we're using CPS in esophagogastric cancer, it may not be the answer in early stage disease, because we give chemo radiation before deciding what to do. And we know that chemo and indeed radiation can cause significant PD-L1 upregulation. And here's just a study we published in 2018 in an animal model, and we gave 16 gray of radiation to these animals, where we were then able to biopsy their esophagus, and we were able to determine what PD-L1 expression was like post-radiation. And you can see pre-biopsy in the middle figure, PD-L1 went way up once we've radiated, but then it tended to trend down over a period of time. But on the far left, we looked at a number of other checkpoints, and they all went up. We know that radiation causes interferon gamma release, and so relying on what the PD-L1 expression is post-radiation is going to be difficult in the adjuvant setting. It's not to say we won't do it, but we know even in some human samples that we looked at during my time at Johns Hopkins, we saw that there was significant stromal upregulation of PD-L1 post-radiation. So that's just a little bit of background as we move in to the large phase 3 study that we presented at ESMO. This is called Checkmate 577, and it was a global phase 3 randomized double-blind placebo-controlled trial. The key entry criteria were that these were patients with stage 2 or stage 3 esophageal or gastroesophageal junction cancers. Patients could have either adenocarcinoma or squamous cell carcinoma. All patients had to have chemo radiation followed by an R0 surgical resection. And then patients were randomized to receive a PD-1 inhibitor or placebo thereafter. We did not allow patients who had a PAT-CR to come on the study. So all patients had some evidence of residual pathologic disease, be it YPT1 or any lymph nodes that were positive. You can see here that the stratification factors were histology, pathologic lymph node status, and here tumor cell PD-L1 expression, and I'll expand on that in a few slides. Patients were then randomized post-operatively once they'd recovered, again between 4 to 16 weeks to allow some people to recover who were a little bit frailer, and we randomized 794 patients, with 532 getting Nivolumab every 2 weeks for the first 16 weeks, and then we lengthened it out to once a month for the duration of the rest of the year, or to placebo at the same schedule. The primary endpoint of this study is disease-free survival. Secondary endpoints, which we will show probably in about a year, will be overall survival. We do not have the overall survival data as yet. The median follow-up for this study was 24.4 months, and it was really one of the first global studies in early stage disease, because you could see here we enrolled patients from Europe, United States, Canada, and Asia, whereas really many of the practice-changing trials before this were from single countries like the United Kingdom or Germany or Holland or some countries in Asia. So this was really a first global effort in this disease stage. If we look at some of the baseline characteristics, the things to really take note of were that we had 60% of the patients had esophageal cancer, 40% had gastroesophageal junction cancer. We definitely had a predominance of adenocarcinoma, 70% versus approximately 30%. And here you can see the PD-L1. Now this was by tumor cell expression, and we showed that only about 17% were greater than 1%, but that was by the PD-L1 28-8 PharmDX assay. This is what we've seen in the published literature. Esophageal junction cancer, the PD-L1 expression at the tumor level is not significantly high. It is anywhere between 15 to 20%. It's the stroma, as measured, as Dr. Shah said, during the CPS assessment, which really indicates the higher levels of PD-L1 expression. This was the primary endpoint of the Checkmate 577 study. You can see it was significantly met, with a doubling in the median disease-free survival from 11 months in those patients that received placebo, again in the post-operative setting, versus 22.4 months in those patients that got adjuvant Nivolumab. The hazard ratio was 0.69, highly statistical p-value of 0.0003. A key point here is the shape of the Kaplan-Meier curves. You can see after approximately 6 months, there's separation of the curves, which remain separated for the entire duration. But it also shows us the poor survival in those patients, median disease-free survival of just 11 months in patients with early stage disease who don't get a pathological complete response to their induction neoadjuvant chemo radiation. So it shows that we really can't be just waiting and watching these patients. We have to give them an adjuvant treatment option. And this is the first one that's emerged with a positive phase 3 study. Excitingly for our patients, in the most recent version of the NCCN guidelines, the committee have given category 1 evidence for the use of adjuvant Nivolumab in patients with squamous cell or adenocarcinoma who have chemo radiation followed by surgery and who do not achieve a pathologic complete response. So that is now in the NCCN guidelines. If we look at the disease-free survival by subgroup analysis, again, picking out some key highlights, We can see histology here. There was, again, we thought there would be significantly more benefit with squamous, but you can see here that we did see a very good efficacy also with the adenocarcinoma subgroup with a hazard ratio of 0.75. We did not see a significant difference in how PD-L1 measured by the tumor cell played out here with hazard ratios 0.73 and 0.75. Pathologic lymph node status, again, you can see here there was a slight benefit, but really nothing that was a huge. And then people have pointed out the esophageal cancer versus the gastroesophageal junction cancer differences. Now, this is not so easy to understand because if you actually just break it down into esophageal cancer and distal esophageal cancer, we have a hazard ratio of 0.74 for distal esophageal cancer. And if you also add in the adenocarcinoma subgroup, we had a hazard ratio in the distal esophagus of 0.55. So we think there's patient demographic or patient characteristic issues at play here. I think we have seen this in other studies with the GE junction not doing quite as well. And so I think this requires us as the community to understand what's happening at the GE junction. Of course, we divide this up into C-word 1, 2, and 3. But I think there may be there could be immunological differences at the GE junction. We know there is epigenetic changes at play here. So this requires more work. But thankfully, there was benefit seen in both subgroups, in the esophageal cancer and in the GE junction subgroup, with the role of adjuvant nivolumab really now coming to the fore in those patients that don't get a PAT-CR. What about the safety? Well, we didn't really see a huge amount of worrisome toxicities. Nivolumab overall was very well tolerated. The majority of treatment-related adverse events were grade 1 or grade 2. If we look at just specifically the immune toxicities, when we were designing this study, we were a little bit worried about whether there would be pneumonitis post-radiation, because we are radiating obviously not quite the lungs, but the distal esophageal and the middle esophagus are not very far away from the lungs. Thankfully, we did not see significant issues with pneumonitis. We did see 0.8% grade 3 to 4 in pneumonitis, whereas in the placebo that was 0.4%. But overall, really quite well tolerated amongst our patients. One of the last slides I have is in any adjuvant. We've never had an adjuvant approval in esophageal cancer before. We hope this drug will be approved in the future, but one of the questions is it well tolerated? If you're going to put patients on an adjuvant treatment for a year, we hope that our patients' quality of life does not deteriorate significantly while on that treatment. And so this is an important slide because we looked at visual analog scales and utility indexes, and you can see the patient-reported outcome analysis revealed really similar overall health status between nivolumab and placebo. Of course, this got a little bit better throughout the year because patients are recovering from a very large operation like an esophagectomy, but we did not see nivolumab causing patients to have significant deterioration in quality of life, which I think was really quite exciting. So what trials are ongoing right now? Well, we're waiting on a couple of other studies. In fact, there's a lot of trials being presented at this conference. Some of them are small, phase 1, phase 2. But one of the ones we are waiting for is Keynote 585, which is a slightly different way to do it. Of course, the other way to treat esophageal or gastroesophageal junction cancer is not to use radiation, it's to use perioperative chemotherapy. So that's the design of this study in patients. Will get either a 5-FU based platinum regimen with pembrolizumab or the FLOT regimen with pembrolizumab, and we'll see if there's an improvement in the chemotherapy alone plus checkpoint inhibitors. Again, different design from the Checkmate 577, which used radiation, and we do believe radiation can alter the immunomicroenvironment. So we just need to see how these trials play out in the future. I don't think we can just presume studies will be positive. We have to wait for those results. The other exciting trial that's happening is a cooperative group study, which is looking at whether we can add an additional treatment option in the form of Ipilimumab with Nivolumab. Again, we know that toxicities can go up as you add combination therapies, especially combination immune checkpoint inhibitors. So we'll need to see again the safety in this and the efficacy. But this study is currently enrolling nationally. There's another study called the Dante Study, which is just using the Atezolizumab plus FLOT. So again, different combination or different PD-1 or PD-L1 inhibitors. If we just look at a broader select ongoing category of the trials, I've mentioned some of the top ones, but there's a whole host of studies looking at different combinations, different scheduling, whether we give it in the neoadjuvant setting, whether we give it in the adjuvant setting, different combinations, whether we add a LAG-3 inhibitor or if we add a HER2 inhibitor in those that are HER2 positive. So a lot of work. We're going to see this data emerging in the next couple of years. We will see if the tumor needs to be taken out, which it was in 577, for the checkpoint inhibitors to work in those patients who may have minimal residual disease, or will they work when the tumor is still in the patient? So that will be the design of, though obviously the neoadjuvant studies, but also the perioperative studies. So we'll have to see if the tumor being intact makes a difference in our tumor type. So a lot to wait for in the future. So I think I'll hand it back over to Dr. Shah at this point. We're going to do two, I think, case histories. The first one will be handled by Dr. Shah, and then I will do the second one. So Dr. Shah.
Terrific. Thanks so much, Dr. Kelly. This was an excellent overview, and I want to congratulate you for leading Checkmate 577. We talked about that study for years, and it came to fruition. And also one point about what you mentioned about whether checkpoint inhibition will work in the context of the tumor being removed or not. One study that I might highlight is Keynote 975, which is a definitive chemo radiation study with or without pembrolizumab. And that might actually help also address that question, whether checkpoint inhibition will be as effective if the tumor is still in place. So we will talk about two case studies here. I'll start off with this patient. This is a 70-year-old woman with metastatic GE junction cancer. She has several comorbidities, CAD and MI, 20 years ago or so, arthritis, hypertension, history of breast cancer. This patient with metastatic disease received FOLFOX. It was well tolerated, but she progressed. She remained active and independent. She then received second-line therapy, but she stopped paclitaxel and ramucirumab because it was causing too much fatigue. Her CPS is 20, and I think currently we have options for this patient. TAS 102 might be an option, and also the CPS is 20. I think everyone here would be leaning toward pembrolizumab because, as we mentioned before, the higher the combined positive score, the more likely to benefit from checkpoint inhibition. And indeed, this patient did respond. This was over the course of 6 months. The patient ultimately had a 40% reduction in her tumor. She went on to have pembrolizumab for 2 years and actually stopped that drug 2 years ago, and she remains disease-free currently. So it does work. Interestingly, for MSI high tumors, as we heard from Dr. Azad, the response happens a median of 2.5 months or so after starting treatment. For monotherapy checkpoint inhibition in the third-line setting, I've seen often the response can happen a little bit later. So let's go to questions from the audience. Here's one. So, Dr. Kelly, is there a type of esophageal cancer patient that you would select to receive chemo plus Pembro in the first-line setting?
Yeah, so you showed the Keynote 590 study, and I think you very eloquently showed all the different subgroups. They really make these studies quite complicated for us, right? Because all the different CPS scores and esophageal squamous cell carcinoma versus adenocarcinoma. I think you pointed out that we're waiting on the FDA, to really guide us on what the indication will be. I think the community feels we certainly will get, again, my own opinion, we'll certainly get an opinion in that CPS greater than 10 category. Is that driving all the benefits in the lower subgroups or not? We'll need to see. They may get some more data. We need to see the peer-reviewed publication. We haven't seen that. We've just seen the ESMO presentation, so it's not always easy to say definitively what we'll see when the paper comes out. But I would think, to answer your question, certainly in that CPS greater than 10, which means, again, like Dr. Azad said, I think we're moving now into the realm of getting PD-L1 expressed, checked reflexly on all these tumors now, because now we may need it as we'll see with the adjuvant setting when we do additional more data. Will we need to have CPS data? So I think it should just become a reflex test now for esophageal and gastric. Like Dr. Azad said, it should be certainly the MSI should be done in colorectal.
Sure. And I think that there's probably still very good activity with squamous cell cancer. So I think, unless a patient has a contraindication, I would consider pembrolizumab with chemotherapy for most squamous cell cancers and the CPS 10 or higher. I agree with you. But I think let's see what the FDA comes back with.
One thing I will point out, and, a lot of American investigators have said this, the chemo backbone they used was cisplatin 5-FU. And, a lot of us don't use that. We use Folfox, obviously. So, can we change the chemo backbone again? That'll be things we'll be debating over the next year or two, I think.
I think we'll be debating it for longer than that. That's what we like to do. How about, there's another question. Which type of gastric cancer patient would we select to receive Nivo plus chemo in the first-line setting? So I think this really highlights the Checkmate 649 study, which was Folfox or Zelox with or without Nivolumab. And for the CPS 5 or higher, there was really clear benefit. I think, again, we have to see what the FDA shows here. They used a slightly different antibody for checking PD-L1 status. And I think one question that I will have is whether or not the FDA requires CPS with that antibody, because in speaking with my pathology colleagues, that requires a different instrument as well. So I hope it doesn't. It would be easier if we could just use one uniform PD-L1 scoring system. And I think, as you were mentioning for esophageal cancer, as you have a lower CPS score, I think probably the benefit for Nivolumab is less and less. And I guess the other thing to think about is what would be the downside. And I think there are a few patients that are really contraindicated for checkpoint inhibition. And I guess, speaking of toxicity, maybe Dr. Azad, you have a lot of experience both in colorectal but also upper GI cancers. Are there absolute contraindications to checkpoint inhibition, either monotherapy, Nivo or Pembro, or combination?
So, clearly the biggest contraindication is a patient that has a history of an autoimmune disorder where they've required systemic therapy for that autoimmune disorder sometime recently. Now, there are clinical trials that are ongoing right now that are looking at subsets of patients that have rheumatic diseases like scleroderma and lupus and carefully testing this concept. But overall, I would say right now that's a contraindication. A history of transplant, of a solid organ transplant as well. With kidney transplants, there have been case reports that have looked at giving immune checkpoint inhibitor therapy and found that the kidney does fail. But of course, a patient can go on dialysis. That's different, of course, if someone's had a heart transplant, of course, or something else that isn't as easy to move back to replacement therapy. So I think, in terms of history, there's that. And then you've got to kind of look at people's clinical picture. So I think, maybe Ronan would even be better to talk about what kind of lung status a patient needs to have in order for you to feel comfortable to take a risk for pneumonitis. If a patient has rampant diarrhea already from proctitis or other rectal cancer issues, then I think that would give me some pause. But to be honest, the benefit in MSI high disease is so high that we often are willing to take some risks in a different way, if it's not an absolute contraindication.
Yeah, just to come in on that, if someone has a history of interstitial lung disease, I would be nervous to give one of these drugs, because we know that the biggest fatalities here are caused by pneumonitis. And so I think that would be another contraindication for me, a history of severe interstitial lung disease.
Yeah, I would tend to agree. Let's move on to the next case. So Dr. Kelly.
Okay, well, this is a case of a patient with esophageal cancer. I think it's kind of a common case we see throughout the United States. So here, this is a 57-year-old with squamous cell carcinoma. Of course, here it says distal esophagus, but predominantly squamous tends to be a little bit higher. Here, the GE junction was measured at 45 centimeters. The tumor was 38 to 45 centimeters. By EUS staging, this was classified as T3N positive disease. PET scan showed no evidence of distant disease. So the patient got, which is the standard, certainly in the US, concurrent chemo radiation followed by resection. And here you can see some of the images of the radiation fields and the PET scan. The patient had a Ivor-Lewis esophagectomy. Pathology report came back as it wasn't quite squamous. It was adenosquamous carcinoma, poorly differentiated. Was located at the GE junction. The tumor extended through the muscularis propria and into the adventitia. All margins were negative. Lymphovascular and perineural invasion were identified. 7 of 17 lymph nodes positive. So the patient YPT3N3MX. This is the case that all of us, every time we go to a GI ASCO conference, historically, we've put up this exact clinical vignette because the crowd are separated because everyone's like, oh my gosh, this poor patient is really in trouble. And as you know, we have people in the audience voting. And before, we haven't really had a good option because we've had all of the academic doctors saying, well, you can't give more chemo, or it's not advisable to give more chemo because we don't really have the data. And you have a lot of the community doctors saying, well, the patient's going to recur if I don't do something. Thankfully now, as a result of Checkmate 577, we do have an option. We have an option, as I said, it's in the NCCN guidelines now, where we can give adjuvant nivolumab. And this patient was enrolled on the study, Checkmate 577, about 12 weeks post-resection, this is kind of what we saw. Most people needed a couple of months to recover from their esophagectomy. So patients or doctors out there don't need to be specifically rushing in to start the nivolumab. In fact, we've looked at some data between whether people started 10 weeks or greater than 10 weeks, and we saw that those people that were after 10 weeks actually did slightly better, which is a different story than what we saw in the lung cancer study, in that very famous lung study called the Pacific trial for inoperable stage 3 disease, where they gave chemo radiation and then adjuvant durvalumab. There, the benefit was seen if you started really quickly. So here, the benefit, we don't have to start really quickly. We can let our patients recover, regain some strength, regain the ability to get calories in, and then you can start it, which I think is very useful information. And then the patient really tolerated the treatment well, received 9 months of treatment, and then decided to discontinue. So again, a lot of the doctors out there will be wondering whether they have to give the whole year of treatment. We don't have data on that, but the majority of patients do tolerate this really quite well. So the I believe there's another slide. Is there, Dr. Shah?
Oh yeah,
there's an audience.
Yeah, we'll get to questions. But I had a question about that patient. So let's say that a patient had some, pneumonitis or some toxicity with the radiation or chemo radiation that they received. Was that an exclusion criteria for Checkmate 577?
So we had to do a scan before we put patients on. And so if there was anything worrisome like that, that would not be advisable. Now, of course, you can see a tiny little bit of pneumonitis post-radiation, and so I think every case being discussed at a multidisciplinary tumor conference would be the wise thing. But the majority of patients that get esophageal radiation are not getting pneumonitis because we're radiating below the carina in the majority of cases, certainly in the US. So you're not radiating the lung tissue per se. So there's not a huge amount of pneumonitis. But it's a great question, and I think something that people just need to be aware of. I think it's more highlights the fact everyone should be aware that pneumonitis can occur, and just to keep a close eye on it throughout the patient's journey with the treatment.
And I see there's one question. So I guess it's related. In your study, in the Checkmate 577 study, since it was a postoperative study, were there different doses of radiation that were included, and then did that affect DFS?
Yeah. So as I said with 590, we have to see the manuscripts. I can tell you the manuscript for 577 is almost finished. This was a global study, and remember, the study started after surgery, so we didn't define what chemo radiation people got. That wasn't actually part of the study. So patients got chemo radiation as per the NCCN guidelines, and then they got surgery. So we didn't you didn't have to just use, one type of chemo. And we know that the normal dose of radiation is anything over 41.4 gray going up. When we looked, we saw some places throughout the world, very small, had used slightly lower doses. But thankfully, I think, we're not seeing a huge impact on the dose of radiation. So, we'll wait to see the publication, but I don't believe that radiation dose is making a huge difference.
Terrific. And I think this is a question to both you, Dr. Kelly and Dr. Azad. So the question is, we talked a lot about immune-related toxicities. Do you notice differences if they're being used kind of early on, either adjuvant or first line, versus later on in the disease? Are there differences in toxicities? Because one might suspect that if you had a lot of chemotherapy, maybe you're burnt out a little bit and your toxicities might be less.
I haven't seen that with single agent PD-1 in my experience between early stage and late stage.
I can't say that I have either.
I have seen it with, not in this particular study, but in a study that I have in the neoadjuvant setting where we're giving chemo and radiation, and then you're adding in a checkpoint inhibitor. There could be that the more treatments you add in, you can get more toxicities, but certainly in the adjuvant setting on 577, we didn't see any toxicities that were different.
Dr. Azad?
Yeah, I can't say that I've really noticed a different either, but I will say that in my tumor type of colon cancer, we've just started using first-line therapy, so I think that we'll see in the next year or two as that moves up front more whether there's a real difference.
Yeah, I think there's a lot to learn. And I guess the other sort of surrogate to that question is, I'm not sure that I see a difference in toxicity when you combine checkpoint inhibitor with chemotherapy versus using it monotherapy, like in Keynote 590 or in Checkmate 649. I think that it'll be good to look at the data once both publications are out, but I'm not sure that there is more toxicity or less for that matter. And then I guess, Dr. Kelly, do you plan to evaluate CPS in the adjuvant setting? Yeah,
well, you probably saw what I was doing during my talk. I was talking about the impact radiation can have on the stromal expression of PD-L1. So the short answer is yes, we will do that. The more difficult answer is, can we really extrapolate what we know about metastatic disease and just assume the immune microenvironment is the same in early stage tumors? I think that would be, a bit too presumptuous. This is the first study in any GI tumor that I'm aware of in the early stage settings. So we obviously have a lot to learn about the immune microenvironment in early stage disease. We will do CPS. That will be in the manuscript. That should be coming out soon. But again, I don't think we can just say, because PD-L1 is such a dynamic biomarker, and if we just give radiation, it may change the expression, and you have to wonder, is that really adaptive resistance if PD-L1 is up post radiation versus if you never radiated a tumor and PD-L was up. So I think that's an important thing for us to highlight to everyone who's listening.
Yeah, well, terrific. I think we'll finish there. I'd like to first thank Dr. Azad and Dr. Kelly for a terrific talk and masterclass on immunotherapy across GI cancers. It's really an exciting time for all of us, and we hope you enjoyed it.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/UFG860. This activity is supported through educational grants from Bristol Myers Squibb and Merck & Company Incorporated.